Hello, my name's Amir Shoaib. In this podcast, I'm going to go through a simple overview of hip fractures. This podcast is suitable for the level of foundation doctors and core trainees. We're going to talk about the clinical features of hip fractures, a little bit about the demographics, the X-ray findings and how this relates to the anatomy, how the anatomy and the pathology relate to the management of these patients, and then I'm going to give you an idea of what operations are involved. There are two groups of patients who suffer from hip fractures. One group is young. They have been involved in quite major trauma, and this has resulted in the fracture of very strong bone. The second group, which are by far the commonest group that you're going to see, are elderly patients. They've fallen from a standing height normally, and they've been non-weight bearing, unable to get up, and they complain of pain in the hip area. On examination, you may find that their leg is short and externally rotated. Quite often, they can't straight leg raise. If we look at the demographics, we can see that the number of people who are aged 60 and over is increasing over time. Over the next 30 years, this number is going to peak, and consequently, we're going to see even more hip fractures. When we look at hip fractures, we don't just consider the fracture in isolation. We have to look at several other factors which can influence management. We call this the personality of the fracture, because there may be two patients who have identical fractures, but for whom different treatment, different surgery may be indicated. We do need to think about the fracture site and the fracture configuration, how many pieces of bone, how many fragments of bone there are, and where they lie. But we also need to think about the social history, where a patient lives, who they live with, how they normally get about, where they have to climb stairs at home, where there's a lift. We also think about their physiological age. There are some patients who are 50 who look like they're 70, and conversely, patients who are 70 who look like they're 50, and we need to treat them according to how they are physiologically rather than just their chronological age. We also need to consider their medical history. They may have other medical comorbidities which are going to influence their management and also influence their ability to recover from their operation because of a lack of physiological reserve. When we talk about fractures, we talk about intracapsular fractures and extracapsular fractures. This is based on the attachment of the capsule to the neck of the femur. Anteriorly, the capsule is attached along the anterior intertrochanteric line, a line which joins the greater trochanter and the lesser trochanter. Anything more proximal to this is deemed an intracapsular fracture, and anything more distal to this line, including this line, is considered an extracapsular fracture. However, it's not quite as simple as that. We have to look at the attachment of the capsule and the blood vessels. Anything within 5 centimetres of the lesser trochanter inferior to that and towards the shaft is called a subtrochanteric fracture, and these are assumed to be pathological until otherwise proven. Now let's look at the blood supply. From the profunda femoris artery, 2 vessels are given off which go into the femoral neck. The lateral circumflex femoral artery exits the profunda and goes up the anterior aspect of the neck of the femur. Its vessels join the capsule at the level of the anterior intertrochanteric line. This means that if there's a fracture above this, these vessels will be damaged. However, if we look at the back of the femoral head, we can see that the medial circumflex femoral artery joins the capsule attachment halfway up the femoral neck. This means that basal fractures are actually technically extracapsular fractures because posteriorly, where the medial circumflex femoral lies, and this supplies most of that to the femur, this will be an extracapsular fracture. However, basal fractures are extracapsular, but the transcervical and subcapital fractures are all intracapsular. So how does this relate to how does the anatomy relate to the short and externally rotated limb? Well, when a patient has a fractured neck of femur, the pull of the iliopsoas results in shortening of the leg. Normally, the short external rotator muscles are opposed by the very strong capsule. If the capsule has been torn, then the external rotator muscles are unopposed and they can turn the leg outwards, resulting in that externally rotated appearance. Let's have a little closer look at the intracapsular fractures. These fractures should really only be described as intracapsular and then either displaced or undisplaced. There is a classification system which is often used, and it's useful to have an idea of this just so that you can understand what is being discussed and what the consequences of these are. The classification was described by R.S. Garden, who was an orthopaedic surgeon in Preston. In the first type of fractured neck of femur, this is an incomplete fracture. The fracture is hinging on the intact medial cortex. On the lateral side, if you follow the neck of femur up, you can see that the neck stops abruptly and then the head starts a little bit more distal to this. This is because there's been a degree of impaction. Sometimes you might see overlap of bone on bone, which appears more white on the X-ray. The trabecular lines, which are lines describing sort of coarse thickenings of the bone within the neck and the head and the acetabulum, usually show a Z-shaped pattern in a valgus impacted type fracture. With this type of fracture, we expect that the blood supply is going to be still intact, as the capsule is not going to have been torn. In the Garden 2 type fracture, which is also an undisplaced fracture, the fracture is clearly complete and the medial cortex is also broken. However, we expect that the capsule has not been torn, and this is the reason why the head is sitting in the anatomical position with no evidence of rotation. This means that the blood supply can be expected to be still intact. Garden 3 type fracture is displaced as a contrast to the undisplaced Garden 1 and Garden 2. In this type of fracture, we expect that the capsule has been torn, and this means that there's a risk of avascular necrosis. In the Garden 4 type fracture, this is an off-ended fracture. Often on the AP film, it will appear that there isn't any displacement. However, if we follow the femoral neck up, it seems to stop abruptly, and then the femoral head starts somewhere completely different. If we look at a lateral view of the hip, we will see that the head and the neck lie in different planes. This is a displaced fracture, and we expect that avascular necrosis could occur. Treatment really depends on our expectations of avascular necrosis. So the intracapsular fractures which are undisplaced are treated with fixation because we're expecting that the blood supply is going to remain intact, and intracapsular fractures which are displaced are treated with replacement because we're worried that the head of the femur is going to collapse from avascular necrosis. This can be remembered by the phrase 1-2 Garden screw, 3-4 Austin Moore. The Austin Moore is an uncemented type of prosthesis which replaces the femoral head and has a stem which extends down the femoral shaft. A Thompson's or Exeter trauma stem are cemented versions of this type of prosthesis. Garden screws are simple cannulated screws which extend from the femoral neck into the femoral head. If a patient is independently mobile, NICE guidelines assert that we should be performing total hip replacements. This is because if we put in a hemiarthroplasty, this can erode through the acetabulum over time and cause pain. These patients would be rewarded with better quality of life if they're given a hip replacement. Of course, patients who are unable to comply because they've got a poor mental test score or because of other comorbidities may not be suitable for a total hip replacement. Now let's look at the extracapsular fractures. Here we can see two different types of extracapsular fracture. The one on the left is along the anterior intertrochanteric line, a so-called basal fracture, and the second one is a more common intertrochanteric fracture extending from the greater trochanter to the lesser trochanter. These fractures can be classified, although I would only expect a foundation doctor or a core trainee to describe this as extracapsular or intracapsular. The commonest type that you're going to see is the type 1 in extracapsular fracture. Very rarely you might see the other types. Sometimes this is important because it can affect management. The management for an extracapsular fracture in the main is a dynamic hip screw. This consists of a lag screw, which is screwed into the femoral head, and a shaft plate, which is attached to the shaft of the femur with screws, and it has a barrel. The barrel has a cross-section which has two flat sides and two curved sides. This is exactly the same as the shaft of the lag screw. This means that there's only one direction that the lag screw can travel in within the barrel, and that's down the axis of the barrel. If this occurs, then because the screw is almost perpendicular to the line of the fracture, the bone is compacted down on itself when the lag screw moves down the barrel, and this means that it becomes more stable. Sometimes with basal fractures, we're concerned that as we put the lag screw in, the head may spin, and this could damage the soft tissues where the blood supply is going in. In order to prevent this spinning, we can use a derotation screw. There are some types of fractures for which a DHS may have problems. The so-called reverse oblique fracture has a fracture which runs in the opposite direction to the normal fracture, which runs from the greater trochanter to the lesser trochanter. It's not necessary that DHS will fail in this circumstance, and some clinical studies indicate that a DHS is perfectly acceptable. However, there is a mechanical risk that this could fail. Certainly, if there's a loss of the medial buttress with a fracture that extends down the shaft, a dynamic hip screw isn't appropriate, as this isn't going to get a good enough purchase on the shaft of the femur. In this case, we need a different type of treatment. This could be with a dynamic compression screw, or these commonly fail through fatiguing of the metal, but more commonly we use an intramedullary nail. The intramedullary nail has a component which extends into the femoral head to gain purchase, and this can control the femoral head, and because the nail goes down the intramedullary canal, it has less of a lever arm acting on it than the dynamic hip screw or the dynamic compression screw, and so these are considered more stable. If we look at the way that we fix these fractures, the position of the screw is very important. The tip apex distance is the distance of the tip of the screw to the middle of the femoral head. If we join these two distances on the AP and the lateral views, if they're less than 25 millimeters, then this means that there's a very low risk of cutout of the screw through the femoral head. However, if it's more than 25 millimeters, then there are risks associated with this of cut out. In terms of clinical management, when you see a patient who has a suspected neck of femur fracture, you should take a history, including past medical history, and you should examine the patient, looking for the shortening in external rotation. You should include a mini mental test score, as this is an important prognosticator for patients with a neck of femur fracture. You should take x-rays, which should include an AP of the pelvis, a lateral of the affected side, and you should also include a chest x-ray. If it's not clear on an x-ray whether there's a fracture and the patient can't straight leg raise, then you may be concerned that there's a knuckle fracture which isn't visible. This could be further investigated with an MR scan or a CT scan. A CT scan is usually easier to obtain. You should take a full blood count, use knees, a chest x-ray, an ECG, thyroid function test, and you should cross-match 2 units. These patients need to have analgesia. Ideally, they should receive a fascio-iliaca block in the emergency department. The use of IV morphine is helpful for pain, but can cause confusion in patients who can suffer from confusion in any case. You need to be worried about how much fluid depleted these patients are, especially if they've been on the floor for a protracted period. You need to prescribe IV fluids not just for maintenance, but also to resuscitate them because they may be dehydrated. If they've been on the floor for a prolonged period, you may also be concerned about rhabdomyolysis and consequent renal failure. It might be worth measuring the CK to see if this has been elevated. You need to provide thromboprophylaxis as these patients are at risk of a DVT, and you can consent and mark the patient if you've been appropriately trained. To be considered trained in consenting, you need to be able to explain to the patient the nature of the operation, and this means that you've either performed the operation yourself or you've seen the operation and are capable of describing this to the patient accurately. You need to be able to explain to the patient what the risks are from the operation, and also what the risks are if they're not operated upon, because there are quite significant risks of prolonged recumbency in bed if a patient is treated conservatively. We consider that the risks of not operating are usually greater than the risks of operating, which was why we try to operate on these patients as quickly as possible. We also need to be able to explain what can be expected afterwards. If a patient is not able to give consent, you need to be able to demonstrate this by filling out a mental capacity form. If you consider that they have capacity, they can then sign a type 1 consent form. If they are deemed to not have capacity, then a type 4 consent form can be used. However, this needs to be discussed with the relatives, not just because it's polite, but also because these patients are at high risk of mortality. Up to 30% of these patients may die within a year of their neck of femur fracture, which is really a pre-terminal event. Therefore, it's important that the relatives are aware of the risks both of surgery and of not operating. Let's go back and look at the differences between internally fixing and replacing the femoral head. Internal fixation is a smaller operation and it's cheaper, but there's a significant risk of non-union and avascular necrosis, and this means that there's a 25 to 30% risk of reoperation, because avascular necrosis can still occur even in an undisplaced fracture. Arthroplasty is dearer, but it results in less operations, and you may consider that in a patient who is only really fit to have one operation rather than repeated surgery, they should have a hemiarthroplasty. And some people consider that patients over 80 should be offered this operation rather than internal fixation for even undisplaced fractures. Some patients may be considered for osteomorph prostheses rather than a cemented prosthesis. Cement results in less thigh pain, but it is a technically more demanding operation. However, you can rely on this to allow mobility immediately after surgery. Cement has risks of its own. Patients may suffer adverse events as a result of the cementation at the time of surgery, and this can even result in death on the table. Also, if cement is used, then it makes revision surgery more difficult if this has to be considered in the future. So, to summarise, we've been over the clinical features of a neck of femur fracture. We've talked about the X-ray appearances, how this relates to the anatomy, and how the anatomy relates to the management.